right, guys. Good afternoon. This is a case we admitted early in December with Randy during a call period here at West. So she's a 78-year-old female that reports 2 episodes of fainting in the last 48 hours. The patient states that 2 days ago, around 2 p.m., she was raking leaves in her garden, and the next thing she noticed, she was on the ground. Denies any prodromal symptoms, so no chest pain, no shortness of breath, no lightheadedness, no dizziness, nothing. And then when she regained consciousness, she was able to stand up and continue with her day. Later on in the evening, while she was sitting on the sofa, she turned pale and was unresponsive for around 4 minutes. Her husband, who's a retired physician, witnessed the episode, and also the patient had no prodromal symptoms and was able to ambulate immediately after regaining consciousness. Since this episode was witnessed by her husband, he got concerned and prompted her to go to the emergency department. Patient was originally taken to an emergency room in Boston where they live. They had some issue with their insurance, so she decided to come to New York City, where they both have a daughter who lives near Mount Sinai West. For the longitudinal history, she was endorsing fatigue and lightheadedness for the last 2 months. And the husband and daughter also endorsed she's been having some cognitive decline over the last couple of years. She's been losing her way around the house, not remembering relatives, and has been having also some paranoid delusions, endorsing that people have been stealing money from her, but her husband says that this is not the case. So I want to pause right now. Is there anything you guys want to ask? Any other things or thoughts you guys have at the moment?
So did she have any chest pain, palpitations, shortness of breath during these episodes?
No prodromal symptoms, no chest pain, no shortness of breath. The only thing she remembers is that she was on the floor and she believes she passed out.
Any confusion or anything after, or like sort of what was her mental status in the minutes to hours after?
Her mental status was perfectly fine from what her husband tells us. She was able to ambulate, was not disoriented, was not lethargic after waking up from these 2 episodes.
Any cardiac history before, any new medication recently?
She only has a history of hypertension and no new recent medications.
Any melena or hematochezia?
No history of this.
No urinary incontinence or tongue biting or eye rolling or anything like that?
No, nothing like this.
Carla's asking in the chat, how long did each episode last?
So since the first one wasn't witnessed by anyone, we don't really know how much it lasted. But the second one, her husband witnessed it, and he said it was around 4 minutes.
Any family history of like sudden death, sudden cardiac death, fainting, anything like this?
No family history of sudden death or other. There is a family history of hypertension, but no sudden death or MIs.
When the patient came in, was the husband there? Were you able to ask more details about what he witnessed, or can we only ask the patient?
Yeah, so he's a kindly elderly retired physician. It at first made us a lot more confused because he did say during the second episode he noticed like some facial drooping when she had this episode, but it completely resolved, and she did not have it when she was in the emergency department 2 days later. Because as I mentioned, they originally went to Boston, to an ED in Boston, had some issues with insurance, and then traveled the next day here to New York City.
Okay. Any motor weakness? Has she noticed like any weakness in her arms or legs, any difficulty ambulating?
No muscle weakness, no difficulty ambulating.
And then you
Is
said,
she on like any certain antipsychotic medication or not?
No antipsychotic medication. She's just has a history of this cognitive decline over the last couple of years, but she has not seen a neurologist or anyone regarding these neurologic symptoms.
So for this patient with these fainting episodes, like what's the term we would use, or based on kind of the information Juan's given you, what would you classify it as now?
something syncope.
Syncope, exactly. And I know you guys had touched on most of it already, but what are, I guess in this case, in general, what are the red flags you need to look for and ask for with syncope?
Exertional syncope.
Exactly. So this lady, it seems like she was raking her leaves the first time it happened, which would be concerning. I don't know how much she was exerting herself doing that. And what other red flags would there be?
Chest pain, palpitations concurrently.
Yeah, I mean, sometimes palpitations can kind of blur between vasovagal, but yeah, especially if you had a cardiac history as well, having any chest pain or palpitations would be concerning for a cardiac cause. Other ones would be if the patient's lying down, right? You don't expect to have like issues with orthostatics or vasovagal when you're lying flat. So that's another one. And also around the prodrome, right? We're used to seeing prodrome if it's like a vasovagal episode. So they'll say they started to feel cold, clammy, maybe nauseous, versus if they're telling you they don't recall it happening, they just woke up on the ground, had no warning, and that will be concerning. And I guess the things that you guys touched on were syncope mimics as well, like important ones, right? Asking about urinary incontinence, tongue biting, because obviously seizure can mimic this way, especially if you don't have a collateral history, but you would expect your patient to be confused maybe for some time afterwards. And the key with syncope is it's quick in onset, but also they have very quick recovery. So they're back to baseline within minutes is the main one. So I guess we've kind of teased out the syncope history. What other like questions would you have, I guess, to try and figure out the etiology regarding what's going on for this patient?
Or was she having any shortness of breath or anything?
No shortness of breath.
Any weight loss, unexplained or unintentional weight loss?
No weight loss, intentional or non-intentional.
Headaches?
No headaches.
After these episodes, was she able like to reorient herself, or was she post-ictal?
No suspicion of post-ictal, just this, as I mentioned, cognitive decline that's been going on for a couple of years, but not after the episodes.
So if you want to move ahead and give us some more of the story.
Sounds good. So past medical history: hypertension, hyperlipidemia, osteoporosis, no known drug allergies, no past surgical history. Medications: she takes aspirin 81 milligrams every day, lisinopril 10 milligrams every day, and atorvastatin 80 milligrams every day. Family history: both her parents died of old age, and her father had hypertension. The social history: the patient is originally from South Korea, has lived in Boston, United States for the last 50 years, is a retired school teacher, has a second home in the Berkshires, Massachusetts, is an avid gardener, has never smoked, no alcohol, no illicit or recreational drug use. So for the review of systems, she has had fatigue, subjective fevers, no weight loss, intentional, no headaches, no blurry vision, is endorsing just some lightheadedness on occasion, has had falls that are these 2 episodes of syncope specifically, and loss of consciousness from these same episodes, no sensation of spinning, no cardiovascular symptoms, no chest pain, no palpitation, no shortness of breath, no abdominal or GI symptoms, nausea, vomiting, diarrhea, no dysuria, hematuria, or urinary urgency, no pruritus, no rash, no lesions or wounds in the skin, no edema of the upper lower extremities, and no depressive symptoms, just the paranoid delusions and the memory loss, and no weakness, no neurological focal deficits. So for the vitals, she came febrile to the ED with a temperature of 102.9, Fahrenheit 39.4 Celsius, heart rate was 84, blood pressure was 118/68, respiratory rate 16, sitting at 95% on room air. We did orthostatic vitals, which as you can see were negative when she was supine. Heart rate was 80, blood pressure 110/78, and standing her heart rate and blood pressure did not change significantly. So negative orthostatic vitals. It's a physical exam. I don't want to read through all of this, but it was grossly normal. Elderly female, she was in no acute distress. At that time, she was alert and oriented. Moist mucous membranes, cardiovascular system was intact. And emphasis on no rash, no bites, warm and well perfused. So any volunteers to give us a brief problem representation? Remember, tell us who the patient is, the temporal pattern of illness, and what is the clinical syndrome?
Yeah, I can try. So this is an elderly woman, with past medical history of hypertension, dyslipidemia, and she's coming in after multiple episodes of syncope occurring in the kind of acute period. They appear non-exertional, and one of them was witnessed by the patient's spouse. There's no pre-syncopal symptoms, no post-syncopal, like post-ictal symptoms either. And the other symptomatology that the patient's endorsing over more of a subacute or chronic period are, lightheadedness, fatigue. You mentioned these delusions, paranoid delusions, and in the setting of like this cognitive decline. And when she came in, vitals were fine except she was febrile, and physical exam was unremarkable.
Excellent. Thanks, Nadim. That was very thorough. Mine was actually shorter.
Sorry.
Elderly female. We didn't have a lot of information, to be honest. Presenting after 2 syncopal episodes in the setting of subacute fatigue, chills, and lightheadedness, found to be febrile, exam otherwise unremarkable, and admitted to medicine for further workup. So can anyone give me like a list of their top 3 differential diagnosis and initial workup that you guys would do?
So what are your thoughts at this point? It's an elderly female, like Juan said. We have these 2 syncopal episodes, and we have kind of some other vague complaints going on in the background, right? This lightheadedness and fatigue, fevers, chills. Her exam is not remarkable, but she has a pretty impressive fever. So what would be your differentials that you're thinking of now in terms of serious things that I need to consider, rule out, or kind of even what's most likely going on with this patient?
I think like some infectious stuff that maybe we weren't really thinking of before should pop in because of the fever. So the differential meningitis, encephalitis, that kind of stuff should be on there. And then just other sources of infection too can really affect elderly patients, like endocarditis. We don't have a source necessarily based on her clinical picture, but yeah, we didn't know that before the fever, so that should be there now, I think.
What other more common infections do you need to think of? So I think endocarditis.
Yeah,
exactly.
UTIs, pneumonias, GI infections.
Yeah, I think those would definitely be common. Meningitis, encephalitis, I think especially with this background of like mental status changes, although it seems chronic. I think it would be more likely like a viral meningitis type picture than like a bacterial, obviously, given her presentation is more subacute.
Cryptococcal, like meningitis as well, is also like very subacute and slowly progressive and indolent. So
Tick-Borne illnesses
Like what?
like Lyme.
And what would her risk be?
She's lives in Western Mass.
Yeah, exactly, right. We don't get to see
Gardener.
too much of it here. Yeah, she's like a board stem question.
Yeah.
And going on that, I mean, Lyme's can cause heart blocks, so it could account for like syncopal episodes.
Yeah,
Yeah.
exactly.
And some cognitive changes in some cases.
So you're thinking that maybe all of this could be explained by like late stage Lyme disease. And I guess with those, where would you begin your workup or where would you start your workup? So say you're on your ED rotation, you get this patient, where would you begin to start doing your workup?
I'd get an EKG and probably just go straight for an echo in this case, just given the sort of sudden loss of consciousness.
So I guess the EKG, yeah, is going to show like what you had mentioned, any heart block, anything like that. What would the echo show you?
I mean, if there's any structural reasons for like, acute decrease in blood flow to the,
Like what things would you look for?
you could have like severe aortic stenosis, you could have like calcified valves. I guess maybe she could, I don't know if like amyloidosis or something like that could cause thickening of the septal wall.
Yeah. Exactly. Yeah. Any like cardiac syncope, you're thinking it's something that's impairing the output, right? So you're looking at things that affect the heart rate and also things that will affect like systemic vascular resistance as well. So things like aortic stenosis, HOCM. Another big one, even though the patient didn't have too many risk factors, but thinking cardiopulmonary, a PE will be another thing to at least have in the back of our minds. So what labs would you start with? Where would you start with that workup? So Nadine, you're thinking infection. Where are you going to start your infectious workup?
Obviously a CBC, looking for leukocytosis, looking for a left shift. For this patient, they're not septic, so I think we can maybe hold off on the blood cultures for now. Other stuff, just like you said, common things are common. Like I would do a UA on this patient, a chest X-ray, even if they're not necessarily having respiratory symptoms, but there was, this like questionable thing of, pallor, or they became, so I would do the chest X-ray too.
Yeah, I think that's a reasonable place to start. And also we want to see if anything metabolic could be going on. So looking at like her lights as well, BUN creatinine, to see if there's anything there. Also finger stick glucose, obviously hypoglycemia can be another mimic.
You said LFTs too, just, I don't know if you said that maybe.
No, that's a good point as well. So if no one has anything else to add, Juan, do you want to tell us what this patient had done and what it showed?
Sure, yeah. So for the differential for us, of course, cardiovascular, you all mentioned all these tick-borne illnesses, parasites, of course, neurologic issues like seizures, hematology, anemia can give you fatigue, and also a lot of autoimmune causes like vasculitis. We're also on our differential. So starting with the CBC, as you guys can see, She had a white count of 4, hemoglobin of 10.7, platelets of 77. BMP was grossly normal, no hypoglycemia. Sodium was a little low, 131. Creatinine of 0.72. And as you can see, she had ALT and AST elevation. So what do you guys think about this CBC and CMP?
A lot of things marked in red. Like what are you thinking now might be going on, or what does it make you concerned for? So, I mean, at least for me, the things that jump out, I don't know what the patient's baseline is, but it seems like she was otherwise normal. She was all 3 lines down in her CBC, which is unusual and is concerning. Like hemoglobin's down, white blood cell count is down. I'm not sure what the diff is, if there's like neutropenia there as well. And her platelet count is down. So looking at pancytopenia and things that cause that or affect that. So like something's either going on in or something's affecting the bone marrow, which is obviously like very broad. One of our main concerns for this patient was infection, but obviously there's a whole host of other things as well. And again, we don't know the baseline, but her LFTs are up as well, which is not normal and maybe not what we were expecting. So when you kind of see pancytopenia like this, what things does it make you think of? And if, like we talked about infection, what infections does it make you think of?
Like parvovirus, viral infections.
Yeah, so a whole bunch
Aplastic anemia. Yeah.
Tick-Borne illnesses.
I feel like Joe Menend has a bias already in this case, but yes, I will take it. Tick-Borne illnesses is another one.
Maybe just a little bit.
You gotta like entertain the idea of like an infiltrative process, like a malignancy or something, and someone who's like elderly and has pancytopenia.
Yeah, so what malignancy, I guess she's elderly, what malignancies would jump to mind or would you be concerned with?
Yeah, like leukemias would be like, I guess, the top of my list.
Yeah, and I guess MDS is one as well that we could, maybe a more chronic picture, but one that we see more in elderly patients, and also any obviously metastatic disease as well can cause it. So if you want to go ahead, Juan, and show us, reveal the rest of her results.
Of course, so the UA was negative, as you guys can see. Chest X-ray was normal, trachea is midline, cardiac silhouette is normal, no infiltrates or opacifications in the lung fields. And the patient, of course, because the history the husband gave us, it worried the ED that she could be having a stroke, a TAI. So they did a CT, which was negative compared from a prior one in 2017. Because of the transaminitis and the elevated bili, she also got a liver gallbladder ultrasound, which showed nonspecific mild gallbladder wall thickening, small gallstones, some sludge, and negative sonographic Murphy sign, and a 1 centimeter incidental hyperechoic lesion, likely an hemangioma. And the ECG, as you guys can see, is grossly normal, no heart blocks, normal QRS. And the echo, as you guys can see, she has a normal EF of 70%, no valvular heart disease, and no intracardiac shunt was seen after injecting agitated saline. The BMP was normal at 73, trope was negative. As you can see from her iron panel, transferrin was 13, iron was low, haptoglobin was also low, and the ferritin was very high, almost 7,000. And when she was in the ED, we ordered a bunch of labs. So they all started coming in slowly. As you can see, hepatitis C, hepatitis B were negative. Babesia, IgM, and IgG were negative. But once we did a parasite smear, the patient had Babesia species 1.5% parasitemia, and which is strange because the serology was negative. But as you guys know, the serology can take some time to turn positive. So we have Babesia. On day 1, she was started on empirical doxycycline because there was a big concern of Lyme disease. So she was started empirically from the fevers. Now day 2 that the Babesia showed up, doxy was discontinued and she was started on atovaquone and azithromycin. That's the treatment for Babesia. And on day 3, things just got more weird. Lyme disease turned out to be positive. The initial panel was positive because she had 3 bands of IgG, but this test has a lot of false positives. So you get a reflex Western blot that the IgM turned out to be positive. Also found to have IgM positive for Epstein-Barr and CMV. So she was restarted on the doxycycline. ID was consulted and they thought maybe Babesia and Lyme were the main culprits. Epstein-Barr and CMV were deemed to be maybe cross-reactivity from the co-infection. They weren't concerned that she was actively having EBV or CMV at that time. And on day 5, a repeat blood slide showed that the Babesia percentage had decreased to below 0.5%. So she was discharged on oral antibiotics to complete a 10-day course of atovaquone and azithromycin and doxycycline for 14 days. So the final diagnosis is Lyme disease with babesiosis. So luckily the patient, since she's from Boston, she followed up here the next week with ID, and her fatigue and lightheadedness had resolved. They counseled her, since she's an avid gardener, on tick bite prevention, on using DEET 28% for her skin, protective clothing, as well as permethrin for her clothing. Fortunately, she left still with, I believe she only left with anemia that was around 8, but we don't have any follow-up labs on our system. Hopefully she followed up in Boston. And just to give you guys a couple of pearls, I got this from the curbsiders. So if the story fits, if you guys have a high level of suspicion for Lyme, you can treat it without sending labs. You guys can do doxycycline. Of course, if the patient is pregnant, or she has an allergy to doxycycline, you can use amoxicillin or cefuroxime that are perfectly good second-line agents, either for 10 or 21 days. And the limitations of Lyme disease testing, the enzyme immunoassays have a high false positive rate. And this ties in very well with Nadine's talk. At least this patient has a very high pre-predictive chance to have the disease. But especially in her case, if you guys don't have the blood results back, you can treat it without sending the labs, since the suspicion was high enough. Another thing they mentioned on the podcast is that post-Lyme residual symptoms correlate well with the severity of the initial infection and the delay of onset the antibiotics were starting. So it encourages further to treat even if we don't have labs. And also for you guys to remember, this was very hard for me studying for step 1. I not only had to study ID, I had to study geography of the United States. So the 3 endemic areas, Northeast and Mid-Atlantic, from Northeastern Virginia to Maine, North and Central states, mostly Wisconsin and Minnesota, and the West Coast, particularly Northern California. And we need to know that Lyme is moving down south to the Carolinas and even in cities where there are parks and gardens. And another thing that I liked is that if you have a flu-like illness during the summer, you need to think of the big three tick-borne illnesses. That's Borrelia or Lyme disease, Anaplasmosis, and Ambodesiosis. The distinguishing features for anaplasmosis, it tends to be associated with high fevers, leukopenia, and thrombocytopenia, and rarely has a rash. And distinguishing features for babesiosis tends to be associated with anemia and thrombocytopenia. And Babesia parasites can be seen on a stained parasite smear. And prophylaxis for our patients, pan tucking into the socks, DEET-based insect repellents, and permethrin-treated clothes are the best way to avoid tick bites. And we need to know where to look, mainly behind the ears, collarbone, armpit, waistband, gluteal cleft, behind the knee, the sock band, and even genitalia, basically anywhere where the ticks can lodge and start feeding. And you can also provide prophylaxis for a tick bite. If the patient has a confirmed tick bite, you can give a dose of doxycycline, 200 milligrams, if the tick is still attached. And you can also consider doxy for post-exposure prophylaxis in patients who live in hyperendemic areas or who work outside. And the patient should always take a dose when there's a tick attached. And that's all I have, guys. Thank you very much.